Hello, welcome to today's webinar on the topic of Medicare Telehealth Proposed Rule, a Centers for Medicare and Medicaid Services webinar. My name is Julie Cahoon and I am from Kaufman & Associates. I will be the moderator for today's session. Before we start the presentation, I'd like to review features of the webinar interface. You should all see the first slide of the PowerPoint presentation in the middle of the screen and a Q&A pod open to the bottom right of the screen. We will be answering questions after the presentation, but you can enter a question at any time into the Q&A pod. For those connecting over the telephone, please hold your questions until the question and answer session. Please note that all phone lines have been muted, and if you need technical assistance during the webinar, please type the question into the Q&A pod within the Adobe Connect platform, and our tech support staff will respond to you. If you have technical issues while dialed in and listening over the phone line, the operator will be able to assist you. Finally, please note that this webinar is being recorded. I will now turn it over to Dr. Susan Carroll with CMS Division of Tribal Affairs. Dr. Carroll?
Thank you, and good afternoon, everyone. Welcome to our webinar for telehealth. As a preview, on August 3rd, 2020, the Centers for Medicare and Medicaid Services issued a proposed rule that announced and solicited public comments on proposed policy changes for Medicare payment under the physician fee schedule and other Medicare Part B issues on January 1st, 2021. Included in the proposed rule in Section 2D, as in dog, are proposed changes to the Medicare Part B payment policies for telehealth services and other services involving communications technology. The purpose of this All Tribes call is for CMS staff to provide an overview of the Medicare telehealth proposals and provide an opportunity for questions and comments. We are interested in hearing from tribal communities about the importance of telehealth services during the COVID-19 public health emergency and the need for continued telehealth payment flexibilities after the public health emergency expires. For comments to be considered, written comments must be submitted no later than 5 p.m. on October 5th, 2020, consistent with the submission requirements within the proposed rule. This webinar, with a link to the proposed rule, will be recorded and posted on the Division of Tribal Affairs website in the near future. This webinar will help IHS tribal health programs to better understand the proposed rule and Medicare encounters via telehealth. At this time, I'd like to turn the webinar over to Emily Yoder from the CMS Center for Medicare in the Hospital and Ambulatory Policy Group and in the Division of Practitioner Services, who will further update us on this important telehealth update. Emily, I'll turn it over to you.
Hi, everyone, and thank you so much, Dr. Carroll. And I'm happy to be presenting to you today and very excited to take your questions. So, Section 1834M of the Social Security Act specifies the circumstances under which Medicare may pay for telehealth services. The Medicare telehealth services are services ordinarily furnished in person and are subject to geographic, site of service, practitioner, and technological restrictions. In response to the public health emergency for the COVID-19 pandemic, CMS was able to waive a number of these restrictions as well as adopt regulatory changes to expand access to Medicare telehealth broadly. So outside of the PHE, the statutory restrictions, that is the geographic, site of service, practitioner, and technological restrictions, those would require an act of Congress in order to modify. The following is a summary of the regulatory flexibilities that CMS is proposing to adopt on a permanent or on a temporary basis. Apologies for that. So for CY 2021, we are proposing to add a number of services to the Medicare telehealth list. These include lower-level established patient home and or domiciliary visits, assessment and care planning for patients with cognitive impairment, group psychotherapy, and 2 add-on codes that are associated with our previously finalized office outpatient E&M policies. We are also proposing to create a third temporary category of criteria for adding services to the list of Medicare telehealth services. So this new category, Category 3, describes services added to the Medicare telehealth list during the public health emergency that will remain on the list through the year in which the PHE ends. This will give the community time to consider whether these services should be delivered permanently through telehealth outside of the public health emergency. I need to pause for a minute. I have some background noise. Okay, apologies. My dog is running around, but she's outside now. So the services, so this temporary category of criteria will give the community time to consider whether the services should be delivered permanently through telehealth outside of the public health emergency. So the services we're proposing to add to the telehealth list on a Category 3 basis include lower-level emergency department visits, higher-level established patient home and or domiciliary visits, certain psychological testing services, and nursing facility discharge day management services. So the following slides are services that we're not proposing to add either temporarily or permanently to the Medicare telehealth list on a Category 3 basis, but we're seeking comments on whether we should either consider these services as temporary or permanent additions. We're seeking comment from the public on whether or not we should make a different decision. So for our communication technology-based services, we are clarifying that licensed clinical social workers, clinical psychologists, physical and occupational therapists, and speech-language pathologists can furnish the brief online assessment and management services, as well as virtual check-ins and remote evaluation services. So for the duration of the public health emergency, we established separate payment for audio-only telephone evaluation management services. While we are not proposing to continue to recognize these codes for payment under the PFS in the absence of the public health emergency, the need for audio-only interactions could remain as beneficiaries continue to try to avoid sources of potential infection. We're seeking comment on whether CMS should develop coding and payment for a service similar to virtual check-in, but for a longer period of time. We are also proposing to amend the frequency limitations for subsequent nursing facility visits furnished as Medicare telehealth. We've heard from stakeholders that these frequency limitations, which again is a once every 30-day limitation on visits provided as Medicare telehealth visits, we've heard that these are unnecessary and limit access to care for Medicare beneficiaries in the nursing facility setting. So we're proposing to revise the frequency limitation from one visit every 30 days to one visit at telehealth every 3 days. We are also seeking comment on whether it would enhance access to patient access to care if we were to remove the frequency limitations altogether, and how best to ensure that patients would continue to receive the necessary in-person care. For remote patient monitoring, in response to stakeholder questions, we are clarifying that the payment policies related to RPM services. We are also proposing a permanent policy, 2 clarifications to RPM services that we finalized in response to the public health emergency. So we are proposing a permanent policy to allow auxiliary personnel to furnish certain remote monitoring services under a physician's supervision, and auxiliary personnel can include contracted employees. We are also clarifying that the medical device supplied to the patient as part of a remote monitoring service must be a medical device as defined by Section 201H of the Federal Food, Drug, and Cosmetic Act, and that the device must be reliable and valid, and the data must be electronically, that is, automatically, collected and transmitted rather than self-reported. In terms of direct supervision, now this isn't actually a telehealth policy. This is a supervision policy, but I'm covering it as part of this presentation anyway. So for the duration of the public health emergency, we adopted an interim final policy revising the definition of direct supervision to include virtual presence of the supervising physician or practitioner using interactive audio-video real-time communication technology. So we are proposing to continue this policy up through the year in which the PHE ends, or through December 31st, 2021, whichever is the later date. We are seeking information from commenters as to whether there should be any guardrails in effect as we finalize this policy through December 31st, 2021, or the end of the PHE, or whether we should consider adopting this policy on a permanent basis and what risks this policy might introduce to beneficiaries as they receive care from practitioners under remote supervision. And with that, I am happy to take your questions.
Very good, Emily. This is Dr. Carroll. Thank you again for summarizing that. As you all saw, that Emily put together a nice PowerPoint presentation, which will be posted to the CMS Division of Tribal Affairs website. And at this time, we'll go to the operator, and if she could help us with instructions for asking questions or commentary to the proposed rule.
And at this time, if you would like to ask a question, simply press star, then the number 1 on your telephone keypad. Again, if you have any comments or questions, please press star, then the number 1 on your telephone keypad. We'll pause for just a moment to compile the Q&A roster.
Additionally, if you have questions, you can type those into the Q&A pod on the Adobe Connect platform.
And there are no questions at this time. Presenters, you may continue.
Thank you. This is Dr. Carroll again. With us today, I know we have Susie Postal, the Chief Information Officer at IHS, along with Chris Four, Head of Telehealth. I want to thank them for joining us. Do either of you have any questions regarding our proposed rule?
Hi, Dr. Carroll. This is Susie. I do not at this time. Thank you.
Very good. Thank you, Susie.
And hi there, this is Chris Four. I don't have any questions at this time. I'm pleased to hear that there's some looking into what may work best after the public health emergency is over. So I'm happy that CMS is investigating what may help telehealth advance even absent the public health emergency.
Very good, Chris. Thank you for joining us. And if you think of anything, please do connect with me after the call. I'm happy to take anybody's emails and questions so we can make sure that the proposed rule gets adequate commentary. Are there any questions in the chat area?
At this time, we do not have any questions in the Q&A pod, but as a reminder to the audience, if you have a question, you can type that directly into the Q&A pod located at the bottom right side of your screen.
And again, to ask a question over the phone line, please press star 1 on your telephone keypad.
Very good. Emily, any other additions to your presentation that you'd like to bring up at this time?
Not any additions. I would just like to remind everyone to please submit a public comment. That is how we will know what would be the best sort of flexibilities to maintain outside of the public health emergency. So please submit a public comment, regulations.gov, and as Dr. Carroll said, the deadline is October 5th.
Dr. Carroll, would you mind repeating where folks can find additional information about this webinar and the information shared?
Sure. So as part of the Division of Tribal Affairs, we can be found on the CMS website, and under the Outreach and Education section of the CMS.gov website, you will find American Indian and Alaska Native and American Indian and Alaska Native link. And by going there, you'll find today's slides. You will hopefully have a recording of today's presentation in the near future, and that's where you can access the link to the proposed rule, which will be found in the Save the Date notice that you registered with. That link is in section 2D, as in dog, has the information regarding changes in additions to the telehealth services for CMS. And through that link, there is also a fact sheet that will help answer some routine questions as part of that website. You can get that information and hear a recording of this presentation again. So CMS.gov, to Outreach and Education, and then American Indian and Alaska Native will lead you to the Division of Tribal Affairs website with this information. Do we have any questions?
We do have a couple of questions over the Q&A pod. One question is, will this webinar be repeated at TTAG tomorrow?
And the answer is no. We do not have this item on the TTAG call for tomorrow.
A second question has come in. Will the proposed rule impact how FQHCs are paid for telehealth services as a distant site? Will it qualify for a PPS rate?
So unfortunately, I am not the right person to answer that question, but if you want to send it to me or to Dr. Carroll, I'm sure that we can get it routed to the right folks.
Okay, very good. We'll say one more time, any commentary or questions before we wrap up today's webinar?
And Dr. Carroll, we have a question over the phone line. Your line is now open.
Thank you. Hi, this is Melanie Forkiller with Choctaw Nation. Thanks to everyone for the presentation and giving us a briefing as to what's being proposed and what you want to hear about. I just have a couple of quick comments, just off the top. We've talked a lot in the last several months about reimbursement for these visits, telehealth visits for Medicare. We did appreciate that the flexibility that's been extended in the way of providing those visits. However, as you all know, for us and in healthcare, the reimbursement is so vastly different from a typical walk in the brick and mortar facility visit for us, and yet we still have all of the same costs. We have our fixed costs. Your facility doesn't magically go away. You pay your physicians. They have time doing this. You still have your billers. You still have everyone in the system that would be supporting that face-to-face visit in a brick and mortar facility, also supporting the virtual visit. And yet the amount of reimbursement is so vastly different. So in order for us to sustain, and I believe we should be sustaining and growing telehealth in Indian country to provide better access to care well beyond the public health emergency, it is a new way of getting greater access to care, but it's got to be sustainable. And that means it's got to be even financially sustainable for us to not only sustain the level we're trying to do now, but also grow it in the future. So hopefully there will be consideration and comparison because we're not the private sector and we haven't been, collecting those kinds of rates. Our rates are published by the OMB in the Federal Register. So, we need to consider how to better approximate those rates in order for this to be sustainable. So that was comment number one. Comment number two goes to the types of technology that are acceptable. I'm really hoping that Medicare will reconsider using phone only in instances where it's needed, even if it's not as broadly as it is in the public health emergency, but some consideration for that because, not only do many of our elders not have, the types of phones that have the ability to do video or other equipment enabling them to do video, but they may not have the connectivity as well. We are very rural, and there are large pockets within the Choctaw Nation, and I know this is true elsewhere in lots of places in Indian country where you cannot get connectivity to do that type of visit, and so that cuts those patients out of access to that. So hopefully you all can consider that and make some accommodation for phone-only visits. Thank you.
Hi, this is Emily. I just wanted to say that all of that is really, really helpful feedback, and I would really ask you to submit that as a public comment to the proposed rule.
There are no further questions at this time. Presenters, you may continue.
Okay, thank you, Melanie, so much. This is Dr. Carroll. Thank you, Melanie, for that great comment, and appreciate your input. And at this time, I don't hear or see any other questions. And again, if you do have comments, please do send them in as a written comment so that you can see the you can get the information from the proposed rule, which is part of the Save the Date announcement. And again, we thank you greatly for attending today's call, for reviewing the changes with us. I want to thank Emily Yoder for her presentation and taking the time to keep us up to date on the telehealth changes. And at this time, pending no further questions, we'll thank you and end our webinar.
Thank you for joining today's webinar. Our session is now concluded. Have a great rest of your day.